Welcome. Today, we are diving deep into Myasthenia gravis and other diseases of the neuromuscular junction. Myasthenia gravis is a neuromuscular junction disorder. It is characterized by two hallmark features: weakness and fatigability of skeletal muscles. Now, what is the underlying defect? The fundamental problem is a decrease in the number of available acetylcholine receptors at the neuromuscular junctions, and this happens due to an antibody-mediated autoimmune attack. Available treatments for MG are highly effective. However, side effects can limit their use, and a cure has remained elusive. To truly understand MG, we must first understand how the normal neuromuscular junction works. At the neuromuscular junction, acetylcholine is synthesized in the motor nerve terminal and stored in vesicles, also called quanta. When an action potential travels down a motor nerve and reaches the nerve terminal, ACH from 150 to 200 vesicles is released. This ACH then combines with AChRs, which are densely packed at the crests of postsynaptic folds on skeletal muscle. This permits the rapid entry of cations, chiefly sodium, which produces depolarization at the end plate region of the muscle fiber. If this depolarization is sufficiently large, it initiates an action potential that propagates along the muscle fiber, triggering muscle contraction. This process is then rapidly terminated by two mechanisms. First, hydrolysis of ACH by acetylcholinesterase, which is present right within the synaptic cleft. Second, diffusion of ACH away from the receptor. Now, the AChR has a very specific structure. It consists of 5 subunits arranged around a central pore. These 5 subunits are 2 alpha subunits, 1 beta subunit, 1 delta subunit, and 1 gamma or epsilon subunit. When ACH combines with the binding sites on the alpha subunits of the AChR, the channel opens. Influx of the cations, chiefly sodium, into the muscle cell serves as the electrical engine driving the depolarization of the end plate region of the muscle fiber. Now, let us talk about some critical proteins at the NMJ. Agrin is released from the presynaptic motor nerve terminal. It then binds low-density lipoprotein receptor-related protein 4, known as LRP4. This Agrin LRP4 complex activates MuSK. MuSK activation then facilitates the recruitment of cytoplasmic proteins, including downstream of tyrosine kinase 7, called DOC7, and Rapsyn, to assist in clustering the AChRs. Muscle-specific tyrosine kinase, or MuSK, is a postsynaptic transmembrane protein that helps stabilize postsynaptic clustering of AChRs. These proteins, MuSK, LRP4, DOC7, and Rapsyn, are important not only in the pathogenesis of MG, but also in some hereditary congenital myasthenic syndromes. So what goes wrong in myasthenia gravis? In MG, the fundamental defect is a decrease in the number of available AChRs at the postsynaptic muscle membrane. Additionally, the postsynaptic folds are flattened, reducing the total surface area. So although ACH is released normally, it produces only small end plate potentials, which may fail to trigger muscle action potentials, and the failure of transmission results in muscular weakness. Now, here is an important concept: presynaptic rundown. The amount of ACH released per impulse normally declines on repeated activity. This is called presynaptic rundown. In healthy individuals, the starting amplitude is so high that this dip has no clinical effect. In myasthenic patients, the already reduced efficiency of neuromuscular transmission, combined with this normal presynaptic rundown, results in activation of fewer and fewer muscle fibers by successive nerve impulses. The result? Increasing weakness, known as myasthenic fatigue. This same mechanism also explains the decremental response to repetitive nerve stimulation seen on electrodiagnostic testing. Now, myasthenia is an autoimmune disorder. It is most commonly caused by anti-AChR antibodies.
These anti-AChR antibodies reduce the number of available AChRs at the NMJ by 3 distinct mechanisms. Mechanism 1. Accelerated turnover of AChRs. This occurs by cross-linking and rapid endocytosis of the receptors. Mechanism 2. Damage to the postsynaptic muscle membrane through antibody-mediated complement activation. Mechanism 3. Blockade of the active site of the AChR, that is, the site that normally binds ACH. Now, myasthenia is not only about anti-AChR antibodies. Anti-AChR antibodies are most common overall, with predominant subclass being IgG1 and IgG3. They cause high levels of complement activation, and they mostly exert their clinical effects via the 3 mechanisms as discussed. However, an immune response to MuSK also results in MG, with experimental evidence showing reduction of AChRs. Anti-MuSK antibody occurs in approximately 10% of patients and approximately 40% of AChR antibody-negative patients with generalized MG. Now, an important distinction. MuSK antibodies exert their pathogenic effect by directly inhibiting the binding between MuSK and LRP4, leading to loss of AChRs and other MuSK functions. Critically, MuSK antibodies are of the IgG4 subtype. As IgG4, they do not activate complement. Therefore, anti-MuSK positive MG does not respond to complement inhibition. Another 1 to 3% of patients have antibodies against LRP4, another critical NMJ protein. LRP4 antibodies, in contrast, are of the IgG1 subclass. They do cause complement-mediated destruction, similar to AChR antibodies, and possibly interrupt Agrin-induced MuSK activation. Now, these pathogenic antibodies are of the IgG class and are T-cell dependent. This is why immunotherapeutic strategies that target antibody-producing B cells or helper T cells, or directly reduce the pathogenic antibodies, or block complement-mediated destruction of AChRs are all effective in anti-AChR positive MG. Although MG is driven by autoantibodies, a significant contribution exists from T cells, particularly T regulatory cells. Treg cells are critical in suppressing activation of other immune cells that have escaped negative selection in the thymus. When these cells escape negative selection and are not suppressed in the periphery, they attack self-antigens. Deficiency or dysfunction of Treg cells contributes to the pathogenesis of MG and many other autoimmune diseases as well. The primary source of Treg cells is the thymus, and the thymus is abnormal in approximately 75% of patients with anti-AChR positive MG. Breaking this down further, in approximately 65%, the thymus is hyperplastic, with active germinal centers detected on histology. Note, the hyperplastic thymus may or may not be enlarged. An additional 10% of patients have thymic tumors, called thymomas. Muscle-like cells within the thymus, called myoid cells, express AChRs on their surface. These myoid cells may serve as a source of autoantigen and may trigger the autoimmune reaction right within the thymus gland.
Let us now move to the clinical features of MG. In terms of epidemiology, MG has an incidence ranging from 6.3 to 29 per million. Its prevalence ranges from 100 to 361 per million. Overall, women are affected more frequently than men in a ratio of approximately 3 to 2. It affects individuals in all age groups, but peak incidence occurs in women in their 20s and 30s, and in men in their 50s and 60s. The cardinal features of MG are 2: weakness and fatigability of muscles. Myasthenic weakness often worsens during repeated use, that is, with fatigue, and/or late in the day. It may improve following rest or sleep. The clinical course of MG is variable. Exacerbations and remissions may occur, particularly during the first 1 to 3 years after disease onset. In approximately 85% of patients, myasthenic weakness becomes generalized, affecting facial, bulbar, axial, and limb muscles, in addition to ocular muscles. If weakness remains restricted to ocular muscles for 3 years, future generalization is unlikely, and these patients are said to have ocular MG. However, rare patients have been seen to generalize more than 5 years after onset of ocular MG. Unrelated infections, systemic disorders, or tapering of MG therapies can lead to increased myasthenic weakness and may precipitate myasthenic exacerbation or crisis. Some exacerbations, however, occur without any identifiable precipitating factors. The distribution of muscle weakness in MG has a characteristic pattern. Let us go through each region systematically. Cranial muscles, particularly extraocular and eyelid muscles, are frequently involved early in the course of MG. Diplopia and ptosis are common initial symptoms. Facial weakness produces a snarling expression when the patient attempts to smile. Weakness in chewing is most noticeable after prolonged effort or when chewing hard or tough foods like meat. Speech may have a nasal timbre caused by weakness of the palate or a dysarthric, mushy quality due to tongue weakness. Hoarseness can occur from laryngeal weakness. Difficulty in swallowing, dysphagia, may occur as a result of weakness of the palate, tongue, or pharynx, giving rise to nasal regurgitation or aspiration of liquids or food. Important note here. Bulbar, neck, and ventilatory weakness can be especially prominent in MuSK antibody-positive MG. Weakness in neck extensor muscles can lead to head drop. Limb weakness in MG is often proximal and may be asymmetric. However, some patients manifest with mainly distal weakness, such as finger and wrist drop or foot drop. There are few important negatives to remember. Deep tendon reflexes are typically preserved. Sensory symptoms, sensory loss, and pain are absent. Now, 2 important clinical definitions. If ventilatory weakness necessitates intubation or non-invasive ventilation to avoid intubation, the patient is said to be in MG crisis. All other worsening short of that threshold is termed an exacerbation. And that brings us to the end of Introduction, Pathophysiology, and Clinical Features of Myasthenia Gravis. If you found this helpful, please subscribe and hit the notification bell. In the next part, we will discuss the diagnosis and management of Myasthenia Gravis. We're just starting this channel, so your recommendations on how to improve future lectures will be highly appreciated. Please leave your suggestions and questions in the comments. Thanks for watching.